So that's it for news. And now I'm going to introduce our speaker. Our speaker today is Professor Mauricio Santillana from Harvard University. So like many of us, he spent some time at UT. So he got his PhD here in 2008. Then he headed to Harvard for his postdoc, and I guess he never left. So now he's a professor at the T.H. Chan School of Public Health and a faculty member of the Boston Children's Hospital. And he heads the Machine Intelligence Lab. So his research mainly focuses on leveraging machine learning and incorporating alternative data sources such as big data from internet search data, social media, human mobility, and weather to monitor and forecast dynamics of infectious diseases. So he's been very busy during the COVID-19 pandemic. He's been providing decision support tools to public health officials, but he's been doing that for a while for COVID as well. So he's worked on forecasting flu and other endemic and emerging diseases such as dengue, Zika, and Ebola. And a cool article I stumbled upon looking at his work was one linking environmental factors and climate change with outbreaks of infectious disease, found a relationship between antibiotic resistance increases in bacteria such as E. coli and higher temperatures, which does not bode well in a context of climate warming. So with that, I'll let him take it away and present for us.
Thank you, Remy. Merci. Thank you for the invitation, and I appreciate the news that I received today. I've learned a lot, so thank you for that. So I'll share my screen so that we can get started with my presentation, and I want to see if you're seeing the right screen. You're seeing that because my computer sometimes gets confused. Or maybe I confuse the computer, who knows. So thank you for the kind introduction, Remy. And just to open up the conversation, to give you a bit of background on my end. So as Remy said, I studied at UT Austin, my PhD in computational applied math. My advisor was Clint Dawson, maybe some of you know him. And when I was working with him, I was doing a lot of numerical analysis and partial differential equations in computational fluid dynamics, specifically trying to understand the way floods happen after a hurricane. And so a lot of my work was on that. I've done work on computational fluid dynamics at the global scale in pollution transport. And then I've done some work on water availability. And in recent years, I've done mostly work on the monitoring and detection of epidemic outbreaks and work at the clinical level with patients, building predictive models for outcomes in patients when, maybe there's a need to change treatment. My lab is, there are multiple members in my lab. Here are 3, 6 more, and many more collaborators. So everything I'm going to say has involves a lot of people. So and I want to be I want to acknowledge them all. And I didn't know if there would be mathematicians in the audience. I assume yes. And so these are some of the keywords that, in terms of my research, the kinds of tools that we use, just for reference. And so let me jump right into the topic. Specifically, the aspiration we have is to use the digital traces that we leave every day, every one of us using our mobile phones or computers, when we search for information, when we look for how to get to an address, when we visit websites, etc. So this information is typically used by these giant companies to make a lot of money. In contrast, we aspire to use that same information and perhaps even some of the methods that they may have to improve, the health and public health around the world, wherever it's possible. And so I assume this audience is extremely familiar with epidemic curves. And so, this is just a motivation slide showing you, the multiple epidemic curves for flu as recorded by ILI.net. And I want to be very precise with you guys because I know that you're experts on this. So I'm not going to give you the watered down version. And so as you see, the timing of the beginning of outbreaks and the length, intensity, and so on, they change over time. And so, some of the goals that we pursue in our lab is to basically estimate what's happening right now, because we know that in order to get current information on an outbreak, as we're seeing with COVID, there's a sequence of steps that need to be followed. First, if you present symptoms or suspect that you were in contact with somebody who may have been sick, then you may go get a test, and then it takes you a while to schedule your test. Then you're swabbed, they send the test somewhere, the test is assessed by a lab, and then results are sent back. And so there are these multiple steps that eventually a number appears at the CDC or the Ministry of Health of whatever country you're at, and says one more case if your test was positive, or it just becomes part of the denominator. And so, so from that perspective, knowing what's happening right this second or today is already to some extent a forecasting exercise, because the information that will tell us what's happening today will be apparent weeks after, or maybe if in COVID, sometimes I feel we're it's a matter of days, but. So nowcasting is an important exercise to assess the current state of the epidemic, and then what may happen in the coming weeks is another important task, to see if things are getting worse, or if say the interventions that we implemented are having an effect on the the status of the outbreak. So, and then we sometimes get more ambitious, and I know that maybe some of you work on this, and we say, this is the total number of cases we expect to see. I just saw that Lauren joined, so hi Lauren. Thank you for the invitation. And so, so these are sort of just the tasks, right? Like, what are we hoping to do? And then you can do this in multiple spatial resolutions. You could do this at this national level, state level, city level, or whatever country you are. They may have a different way to organize their geography. You can go down to hospital, and then you could do this for endemic outbreaks or emerging outbreaks, and so on. So, so here's just a slide to remind me. So I spent some time doing weather forecasting, and there, over time with the advent of computational power, we've gotten better at predicting what's going to be the temperature tomorrow, or say within 36 hours or 72 hours. And this curve shows you that over time, the accuracy, if you think this is like 100 would be a perfect prediction, we've gotten better. In contrast, in epidemic forecasting, in an ideal world, which we live in a non-ideal world, but in an ideal world, if an expert with good knowledge said or brought up news to a city or a country that an outbreak is going to happen and it's going to lead to many deaths, then in principle, people will react to that. So if you have a model that predicts what will happen, if there's a reaction from people, then that will change the conditions of that the model may have taken into consideration. And that means that your predictions will be wrong, and hopefully will be wrong for the right reason, namely that the reaction of people will have led to a reduction of deaths or infections. In times of COVID, we've noticed that this feedback effect from humans reacting to evidence is more complicated, and it has we recently made publicly available a paper where we showed that counties that leaned Republican during the presidential election, unfortunately during the third wave of the outbreak, suffered a lot more deaths, and so that brings up the issue that it's not, the information is not people do not think of our predictions as an objective statement or the best to our ability. They just it was one more data point that they may listen to or not. And now down to the mathematical questions. This is a summary of how we tend to work. We like introducing the use of data sources that were not originally designed to monitor outbreaks, but that may be proxies for human behavior and changes in it, such as the way people are tweeting, or access to Wikipedia, or the way doctors are searching, or the general population, etc. Whether the weather conditions are the appropriate ones to promote spread, or if it's, say, a mosquito-borne disease, whether there are mosquitoes in a given area or not. And of course, the role of human mobility. Now that we have phones and people are concerned that with the vaccine, you're injecting a GPS onto you. But we don't need to be injected with GPSs. We have the GPS on our phone, so we're already being monitored. So, if the vaccine has a GPS, I know it's probably a bad joke. I apologize for that. In any case, so a lot of the knowledge we've built has come from studying influenza, because it has been very well documented throughout time. We have a lot of data, and so we use it as a test bed. And so I'll spend some time on this, and then I will show how our approaches, we've been able to extend that to other diseases, including COVID. So when I first started working on this, one of the goals that I was interested in mapping this discussion, in social media and search engines, and etc., into an epidemic curve, right? Could we use that information as a way to produce a signal that tells us earlier or before traditional data sources that are based on hospital data or healthcare based, in short. And so that was the aspiration at the time. And so, this is the punchline. The answer is yes, in many cases, and depending on the spatial resolution, it will be better or worse, and depending on the season, etc. As many of you know, we may be more accurate or not. And this video is showing you in black what the ILI, activity influenza-like illnesses, the percent of people affected by those in the US at the national level over time. And what you see here with this red worm with error bars is a cone of uncertainty with our forecast of the next 4 weeks. So this is historical out of sample predictions, and we continue sending.
So yeah. The red line that you show, that sort of the trails, what is that? Is that a like a 2 week ahead prediction, or what is the red line?
It's the one that remains?
Yeah,
it's 1 week in the future.
Okay.
Yeah.
Thanks.
Yeah. I knew, Lauren, that you have a clinical eye here. So yes, thank you for bringing that up, because otherwise I would have 4 curves there that leave a shadow for the 4 time horizons that every week we produce. So yes, we chose to just keep the 1 week ahead. And so here's again the curve. I mean, I can go back if you want, but it's something to be noted, and I guess this audience is well trained to identify, is the fact that the black line is not as stable as you think, because there's some degree of backfill. That means that when a number is published, it may be changed next week for whatever happened today, or 2 weeks in the future. There are some, and so that's why the black is a little bit like it's shaky. And so the long story short, before I move on, is we used to just use, say, Google searches, or just Twitter, or just and I'll try to convince you that what we've learned is that we should be using everything, because everything is complementary. And even though if you build a single model based on a different data source, it may look to be the best compared to others. Other models with using other data sources may add some complementarity to the predictions. And then I'll try to convince you that this can be used in other diseases, including emerging outbreaks such as COVID. And so this is a little bit, you know, in a historical way, how I got involved with this. So I started following the fact that Google had built a platform called Google Flu Trends, and probably many of you remember this. So they were prominent, and you know, the main goal or the main idea was, and this is a plot produced by us, not by Google, but it summarizes the concept, which is, if you look at the red curve here, that's a number of people searching for the word bronchitis in South Africa, and the black line is the number of people who showed up with a positive test of influenza. And so you see the overlap, and so they're not perfectly matched, but they kind of you know, look on top of one another. And the beauty here is that the red line is available at least 2 weeks before the black. So that's it, right? So that means that if you could find a way to map the red into the black, then you would have an estimate of in real time of what's happening. So that's sort of what Google did. And you know, it led to multiple problems. The first one had to do with the fact that Google Flu Trends was deployed a few months before the H1N1 pandemic, which by now looks like a non-pandemic, but it was a pandemic. And you know, they couldn't detect it. So their systems were dramatically under predicting what was being observed after the fact. You know, in red here is the curve by the CDC, and in blue it was, you know, their estimates. And so they worked hard in the next 2 years to show us that they not only had a winter detector, but that they could monitor the outbreak of flu, at least in the US nationally. And they were bold and deployed this tool for a lot of countries. So it was great. But then, you know, in 2013, they had another big discrepancy with observations where they over predicted by more than 100%. And so people felt like this was not going in the right direction. And, you know, they made it to Nature again, but not for a good reason. And so, you know, there was just no confidence that this was going to go anywhere. And at the time, I had a student, an undergraduate at Harvard, who wanted to see if we could produce something better. So we looked at the input variables that Google was using for their models, and soon realized that they were not sharing them, but they were sharing a low quality version of them. So our thought process was, if we use the low quality version of the input variables they use, we implement their methodology, and then we come up with another methodology that may beat the baseline that we had obtained with their methodology on this low quality data, then, you know, at least we could claim that we're doing it better. And so, you know, we basically brought some concepts from weather forecasting, namely data assimilation techniques that incorporate, that retrain the models so that they fit reality better. And just using some, you know, penalized regression with dynamic training, we soon realized that our predictions with this low quality data as input was leading to much better predictions than the ones that they were distributing. So we were a bit shocked because, you know, we knew that they had much higher quality of information, and yet we were able to just produce another methodology that was superior to what they had. Google inspected our predictions, and they acknowledged that it was better. So they fixed their engine, and you know, in the following months they wrote another paper, even fixing what we had proposed with another technique that they felt it was better. And you know, we were also working in a parallel effort, and so we published another paper saying, well, in fact, this one that you guys published it can be improved. And at that point, they got in touch with us, and they told us, you know what, we're just going to stop doing this. So great. And so the way I tell this story to my students is that we checkmated them and we did a better job. But in reality, it's a little bit more complex. The reality is that they were not really making money profiting from this, and they were not putting enough resources. So it was not interesting for them as a company to continue this effort. So, but they offered to share the data with us. So in their blog, they said that they would open up their data to us and that we could continue that work. And so, you know, it was all over the news that Google Flu Trends was going to disappear, and it disappeared. We decided that one of the biggest failures of Google Flu Trends is that they were not actively collaborating with CDC officials or with people who would be the direct users of this technology. And so we decided to get in touch with the folks at the CDC. We started working with them, and that led to some interesting papers in the future. But in parallel, we were also trying to identify whether, following what clinicians were searching for could be useful, or if, so these cloud-based electronic health records companies, they can, in the same day, give you an estimate of how many people are being prescribed different drugs, for example, how many people showed up with fever, etc. And then we were also looking at Flu Near You, that you may have heard, is like it asks you every week if you're sick or not, or if you have symptoms. And of course, we were also looking at Twitter, and we made progress on all those data sources, and we showed that, in fact, a very interesting data source that could be used to monitor flu was what clinicians were searching. That's really interesting, and it's an early signal. If you look at electronic health records, even though we had a really small sample of the entire country, we were able to produce extremely accurate estimates of current week, next week, and then 2 weeks into the future. And so we were confident that we now had multiple models. And as I said earlier, I remember being at the White House, and I don't know, Lauren, if you were in 2014 with in the office of the Vice President with Dylan, George, and all of them. But they asked me, you should just send us the best ones, because we just don't want to waste time looking at many predictions. And I said, look, but when you have multiple methods, wouldn't it make sense to see if they work better together? And so we wrote this paper where we in fact showed that if you bring their efforts together, then models may work in a more robust way. So here, what I'm showing you is each row is a different method, and related to what I showed you before, with different metrics of accuracy. One is correlation, one is error, root mean square error, and some other metrics like hit rate is how frequently you get the derivative right. But what we showed is that in almost all the relevant metrics, namely in terms of error, we could reduce the error of even the best one. So that even the ensemble was better. Although in practice, we've tried this technique and we find that frequently there's a stronger methodology during a season and during in a given location for a specific disease. But when we use an ensemble, we typically get that the ensemble is, almost of the same accuracy, but it's always robust. In other words, the top performing model may flip across locations, seasons, disease, but the ensemble tends to be always at the very top, namely top two, either the best or the second. And so, those were the lessons we had learned from flu. And we were curious to see, everyone at the CDC told me at some point, well, yes, we know a lot about flu, so why don't you try doing something more impactful? So we continued doing work on flu, and this is just another effort we published where we also incorporated the fact that when there's an outbreak in a neighboring location, the risk of seeing an outbreak locally increases dramatically. And so by looking at the synchronous waves of influenza across states, we could incorporate the fact that a neighboring state was seeing increases in cases, and we could assess to what extent that information could improve your predictions. And so we showed that this method could improve predictions and so on. And so I'm going to fly now over these other additional efforts. Here, we show that Twitter could be used to monitor emergency department visits in New York City. And then, in terms of spatial resolution, we had shown that state level could be done properly. with robustness. And here they ask us, well, why don't you do it at the city level to see what is the limit of your approaches, right? Because we use a lot of aggregated information that if there's a point where you may be in conflict with the privacy of users if you go into very fine spatial resolutions. So they said, well, while respecting the privacy, can you still get estimates at the city level? And the answer was yes. We did a pilot study in Boston. We published a paper there. Let me go. And then I gave this talk a few years ago at Boston Children's Hospital, and they said, could you predict the number of emergency visits in our hospital with your methods? And the answer was yes. They passed a time series like this, and then, we showed them that if we incorporated a lot of data sources in a similar fashion, we could predict really well in an out of sample fashion what the number of people who would need care the next day or the next 2 days. And then we've also, one of my students was really enthusiastic about using deep learning into this influenza prediction, and I was a little skeptical. I was a skeptic about this, but she showed me that for long-term time horizons, like predictions of 8 weeks in the future, where most of our models actually behave horribly, that deep learning approaches could lead to stable predictions, that they didn't decay, the error didn't decay as fast as in some of the methods we had. So, so we published that paper and documented how we did that. And in more recent times, we've combined efforts with people like the team from Alessandro Vespignani at Northeastern University, who used, mechanistic models, namely probabilistic SIR models with local features to assess where the outbreak will go. And we've combined strategies from our short-term forecasting methods using machine learning and his team. So let me now jump into briefly stating that these methods, again, had some degree of success in their corner for influenza, and so we showed, in fact, that using Google searches, we could also improve the prior platform of Google for trends in multiple Latin American countries, in some countries in Africa. And then this was a paper we didn't publish it before the COVID outbreak because it was in review, but we were starting to show that, if you look at the top left figure, you see in yellow the number of people who were searching for the term yellow fever on Google, and in gray you see the number of cases. Here, what was important is that yellow fever was an emerging outbreak in Angola, and I forget the year here, but the important thing is that we didn't have anything to train with, because for machine learning methods, you need to train a specific set and then predict in another sample. Here, we didn't have any data to train, so we were wondering, is there a use in these data sources to at least give us a sense of how things are evolving? And for this outbreak, I remember it was until March or April that they started sharing, at least with the public, via reports, the number of people who had been affected. So from January to, say, mid-March, people didn't know what was happening. They knew that there was an outbreak, but didn't know if it was bad, if it was getting better. And by just staring at this curve, you see that the timing of the peak, it's not perfect, but it gave you a sense that after mid-February, the outbreak was starting to go down, and it kind of coincides with the gray in a qualitative way. And then we have other emerging outbreaks here. For some, for Zika in Colombia, we actually had shown that with very little training, you could already produce meaningful estimates in real time. So we were feeling confident that this was going to go somewhere. And then COVID happened. Oops, sorry, I hit the wrong button. And I'm going to go to COVID now. So I have many other slides about dengue and weather and stuff like that. And if you're interested, I'm happy to to go there, but just in the interest of time, I'm going to head to COVID. So for COVID, you know COVID, you probably know more than I do. So, and you know that maybe it came from bats, or who knows, the WHO is in the process of deciding that, maybe it leaked from a lab. And again, I trust that all of you are very familiar with the way it evolved, and it was clear that by late January, it had leaked out from China. And very soon in February, we started seeing dramatic increases of cases in Italy and Iran. And at that point, we knew that it had become a pandemic. And so, so this, you guys are familiar with this. And it was, I think, about April. So as you see here, Italy was going insanely in terms of cases, and then, of course, Iran as well. And so I think by April, it was almost everywhere. And so for us, we looked at this map from the New York Times. I think it was in mid-March. And what was striking about this is that the spread, the geographic spread, with so little numbers. In other words, the circles here represent the number of cases in all these different locations. And it was hard to reconcile the fact that we had so widespread geographic spread with so little numbers in the in the cities. And of course, we know that there was very poor testing at the beginning of the outbreak. And we had read work from our colleagues in Columbia University, the team of Jeff Shaman. I think you have invited him, or I mean, I know you guys know him well. So we wanted to see whether we were dealing with an iceberg or the ice was just floating, right? And we knew that this would affect policy. So very early on, this ended up being published in June 2021. That's the beauty of academic publishing, right? Like, we wrote this paper in April 2020, but then eventually it got accepted more than a year after. But back then, we just made it publicly available through preprints. And what we found is that using this similar approaches, similar data sources that we had used for influenza and for other diseases, we could triangulate what we estimated was a number of infections. And here, an important result was that in general, we were finding that the case counts that were being published by the Johns Hopkins platform or any other official data source we estimated about 1/5 or 1/50th of the actual number of infections, so that you needed to multiply by 5 or 50 at least at the state level to get a number that would reconcile the multiple things that were happening. And this is shown graphically here, where the black dots show you what had been reported up to April 4th, the cumulative case counts or confirmed cases. And here we have multiple dots of multiple colors, where we had used either a different data source or a different statistical technique to assess the number of people we suspected in each state had been sick. And the scale here is a logarithmic scale in base 10. So each crossing of these vertical lines is at a factor of 10. And so you see that in multiple cases, we had a dramatically higher number of cases. And so just to give you a flavor of one of those techniques that we were using, we were monitoring ILI, influenza-like illnesses visits, and here shown in blue. We were also monitoring the confirmed influenza test coming back to us, because these systems were up and running at the time. And what we were seeing is that the number of people with confirmed influenza was dropping down as expected seasonally, but the number of ILI visits were going up. So this discrepancy across states gave us a sense on cumulatively how many people we suspected were infected. Another method we were using is with a very uncertain infection fatality rate. We were counting the number, we were monitoring the number of people who had died with a confirmed COVID-19 diagnosis. And we knew that, at the time we estimated 1 in 200. So of 200 infections, you could expect 1 to be to die. And now we know that this is a more subtle way to quantify age groups are important, etc. But just with a back of the envelope calculation, one can deconvolve. If you have 10 deaths today and 1 in every 200 people die, then you had to have 10 times 200 somewhere in the past number of cases. And that's another way in which we could triangulate likely number of infections. And we had 2 more methods, and that was one of the early pieces of work we did. Let me check at the time. Then again, we had used multiple data sources to monitor and track influenza, so we thought, why don't we do this for COVID? And again, this involved lots of people. So we started looking at Google searches, what clinicians are searching, and smart thermometers, which are not smart, but they just sync via Bluetooth with your phone. So if you have a fever, they record it and it goes to the cloud in the same way that Fitbit, sends your information to some central database. And so what we were seeing here is that, so this is for New York, but each column here is a snapshot in time of information that was available, say, as of March 1st, 13th, the 23rd, and so on. And the top row shows you what we call traditional data sources, namely healthcare-based, right? So number of confirmed cases, number of confirmed deaths, and this anomaly that we had presented before, meaning the discrepancy between ILI, influenza-like illnesses visits, minus the number of people who were being confirmed for influenza. So I showed you this discrepancy before. So that's what the yellow line here represents. The middle row shows you data sources that are just not designed to monitor health, but they are proxies for human behavior. And the bottom one is human mobility as captured by mobile phones and so on in an aggregated fashion. But what you can see here is that by March 13th, we had this elbow, this very sharp increase, exponential growth in multiple data sources that we were seeing. One is Twitter, one is Google searches, one is these thermometers. Up to date is somewhere here, which are clinician searches. And the black is a model by our colleagues at Northeastern University. And it was with a plot like this, but for Massachusetts, that we went and spoke to mayors in the city. There are about like 50 mayors in the Boston area, and the governor, and we showed them things like this, and we said, look, Italy is a disaster, Iran as well, and we suspect that in our population, given these L shapes, we're in an exponential growth stage, so we should be thinking about lockdown. And they were really open and receptive about this, and 2 days later, they locked down the entire city. But they were asking us, but why are we not seeing anything in our traditional data sources? As you see here, the deaths were flat and cases were not showing up. And we said, well, because we're not testing enough. And that was true at the time. Then by March 23rd, we met again with them and we showed them, look, our data sources show like a maturing outbreak. It's just going through the roof. And yet they were only seeing this evidence that things were going up. But then by April 18th, we were seeing this curve in terms of deaths starting to go down, and they were asking us, do you think that the lockdowns here represented by these 2 different curves that show the reduction in terms of human mobility, do you think they're working? And according to these data sources, it could show that there was some loss of interest to use searches and so on. But, given that all of them had a similar shape, we felt we can probably say safely that lockdowns have worked. And so by May 30th, this on the traditional data sources, it was confirming what we were saying before. So we thought that we had some early warning system that was useful. And, so we have multiple time series here that we showed to the decision makers, but the summary statistics here are that, an uptrend in cases, we could detect it with different methods or different data sources, multiple days before they were observed at the state level. And we have a box plot here because we have 50 states and we were assessing each one, so you don't have a single number. But one of the important things that we did is that we built this Bayesian estimator of the likelihood that an outbreak would happen, given the fact that multiple data sources were activating or were growing exponentially. And so that was one of the contributions of this paper. And let me see, I probably should wrap up in 3 minutes or 4. Is that okay, Spencer? Yeah, okay. So we did additional work, again, exploiting these data sources that are alternative and not necessarily designed to monitor disease activity. But here, what I'm showing you is a map of Santiago de Chile, the capital of Chile in South America. And in the colors here mean how affluent the area of the city is in terms of income and access to healthcare, etc. And we order these, they call them, so this could be municipalities in the US. They have a different name in Chile, but you know, the highest income here, lowest here. And as you can see, the volume of cases, you know, you see more in the bottom area. And in terms of deaths as well, the x-axis is time, and you see higher incidence or higher number of deaths. And what you see in this one specifically is that here the y-axis shows you the percent reduction of human mobility across these different municipalities. And what you can see is that the red is, you know, leads to fewer reductions, and the green, you know, they see more dramatic reductions in human mobility, which reflects the fact that more affluent regions had more the privilege to just stay at home, right? Whereas, you know, poorer areas needed to go out to have an active economic activity to be able to buy food, right? And so, the summary of this work was that unfortunately, the pandemic, and it's not only about the pandemic, but you know, the poorest sector of the population typically gets affected more significantly than the wealthier ones, right? And then we had other projects with collaborators in the UK showing, this was much earlier in the pandemic, showing again with data sources like changes in mobility and so on, the effect of lockdowns and what would have happened if lockdowns had not been implemented in China. And these results were, you know, really dramatic in terms of the number of deaths that were averted, if that makes sense. And later on in the pandemic, we've also done work on, you know, the effectiveness of vaccines. And let's see. Well, another important piece of another paper that was crucial in the pandemic is this one. And you may remember seeing a plot like this for influenza. So if you see the reproductive number for influenza as a function of specific humidity, which is monotonically related to temperature in a way, namely hotter air can contain more humidity. That's the fact. But depending on the availability of humidity in the air, you can saturate the air or not. But what this shows is that drier conditions that would be on this side are more favorable for transmission of influenza. And so this intuition that also has been observed in other coronaviruses circulating in our population made, you know, President of the US, President of China, to say around April that, you know, the pandemic was going to go away in the summer. So we started looking at the places where the pandemic had already been present. And, you know, so here is humidity. And this is earlier in their own epidemic in China. Here's temperature, here's humidity. So what we were not seeing is this decay that I showed you before, right? That, you know, colder places, less humid places were seeing a much higher proportion of transmission than others. And instead here, it had more to do with, you know, density. Hubei is the province where Wuhan, the epicenter of the pandemic was. And so basically what we were seeing is that warmer areas were still experiencing outbreaks. And in fact, that there was some kind of a sweet spot of temperature where transmission was happening worse. But I guess the take-home message here was, no, if it gets warmer, we have no indication to suggest that things will stop. Like, it's not that the R naught is just below 1, and this is a more dramatic one for a different time period. So, in other words, this expectation that it will behave like other coronaviruses or the flu that are now endemic, it's just a misinformed statement. And we know what happened in the summer. Nothing went away. A lot of the population was susceptible. Anyways, I'll stop there, and I'll take questions, and let me just, yeah. I hope it wasn't too much information in too little time. Thank you.